So, hello everyone. Good evening. So, I hope all of you have read your first two chapters, that is your sterilization, extraction, impaction. Right. So, we'll be solving few MCQs today. So, as it is the initial MCQ, so I will be a little slow. I'll be explaining you word by word. But actually, this is a very easy topic. So, before starting, I would like to know, please put it in the chat box. Have you read it or not? Yes, no, Y, and N. Please put it in chat box. Have you read about extraction so that we'll solve that MCQs today? Yes, answers are coming. Yes. Okay. Okay. So I guess you have read it. You have not read it. But still, it is the initial days of your preparation. No problem. So extraction we have studied as a main question chapter in our new undergraduate. And now you will see that how questions are being asked. Similarly, impactions is just the main question and some short notes are there in the UG exam. How questions are framed into MCQs, we will be seeing that. Please note that there are many more MCQs. I have just picked the prototype so that you will be able to answer all the related questions as it is. Okay, so let's start now. So I will be giving you a question. Four options will be there. Please put it in the chat box, your answers. If it is wrong, no problem. We are in the starting and in the beginning, most of the people don't know. No worries for that. Okay. So put it in the chat box, your answers. Accordingly, we'll proceed. So we are going to discuss today extractions and impactions. Okay. The first question, very simple question, which we have already discussed in our theory section also. Please put it in chat box, whatever you feel. The mechanical advantage obtained from the wheel and axle principles of elevator is 2.5, 3, 4.6, and 6. I want all of you to answer. Even if you are wrong, no problem. I repeat, please answer. So you will know that what is happening. Please participate. Wrong doesn't matter. Okay, fine. So, and be quick, okay? The mechanical advantage obtained from the wheel and axle principle is values are there. So what is this question? So they have given an instrument, right? The wheel and axle, this is the one of the principles. We have got wedge principle, lever principle, wheel and axle. So directly they are asking you the mechanical advantage. So this is like a direct question. The other way of asking the same question is they can give you an examples. Winter's crossbar, apexo elevators, couplant elevators, straight elevator, and what is the mechanical advantage? That's the second way. So this question, direct question, it is wheel and axle, and we know that the answer is 4.6. Okay, so it is 2.5, 3, and 4.6. So I guess all the related three questions, three MCQs can be generated from here. This is the first question. So our Winter's crossbar elevator, this is the examples. You can take a screenshot of this. Crossbars or Winter's elevator, which uses wheel and axle principle, it has got 4.6. So if your weight is 60 kilogram, 60 kilogram, and you are trying to put the elevating force on the tooth, so 60 into 4.6, almost like 250 something kilograms of force is applied on the tooth. Then apex elevator, wedge elevators, and extraction forceps, all your forceps, they use 2.5. Straight elevator uses 3. Okay, so this is wedge, lever, wheel and axle principle. So all this left hand side examples, please make a note. There are many more in the textbooks. You'll have to read it. It is there in Dental Pulse book. You'll have to read it. It is there in Dental notes. You have to learn more specifically. Okay, so next question. So all of you got the first question right. Next question. Just derive from here only where we left. Apex elevator utilizes which principle? Apex elevator utilizes which principle? Rather than telling the answer, I would say whether 2.5, 3 or 4.6. Yes, correct. Second person, third person, correct. Be quick. You can just write options, okay? No need to write the full answers. You can just write A, B, C, D, like that's all. So it's the wedge principle, okay? Apex elevators utilizes which principle? The wedge principle. And we know that this is the examples. The apex elevator, generally wedge principle. Straight elevator, lever and wedge. Tires, lever principle. Apex elevator, wedge principle. Crossbar is wheel and axle principle. And small straight elevators is also called as shoehorn forceps. It's a new thing. Please write it down. Shoehorn forceps. The small straight elevators are called as shoehorn forceps. It is also called as a forceps, but it is an elevator. So this is an extra point. So you should know what is lever, wedge, wheel and axle principle, what is the mechanical advantage, what are the examples of it. So either way they can ask you the, so almost like 10 to 15 MCQs can be generated from this very particular topic. Next question. The elevator can be used to advantage when? We are using an elevator when it can be used to maximum advantage. One, the tooth to be extracted is isolated. Second, the interdental bone is used as a fulcrum. Third, the adjacent tooth is not to be extracted. That is the time where you use as elevator. Or the fourth one, multiple adjacent teeth are to be extracted. Yes, think of an answer, whatever it is. It may be wrong, no problem. Think of an answer. Everyone participate. I want everyone to be participating. All of you. Right or wrong doesn't matter. I am repeating it. Okay. Okay. Right. So all of you have written this. Okay. The answer is correct. See the principles of elevators. Please understand what I am trying to tell you. Okay. All of you have told interdental bone is used as a fulcrum. Yes, that is a principle of using elevators. Yes. But question is what elevator can be used to advantage when? I will say the fourth is the option. Multiple adjacent teeth are to be extracted. That is called as Stobie's method of extraction. Stobis. When two premolars are to be extracted, I will put the elevator in between and just rotate. I don't have to bother mesial tooth, distal tooth, interdental bone, nothing. Put an elevator and rotate. So maximum advantage. Both the teeth are extracted at a single point. So you all have told interdental bone is used as fulcrum. That is correct, but that is principles of elevators. That is the principle how you have to use. The interdental bone should be used as a fulcrum. The tooth should never be used as a fulcrum. Adjacent tooth should be never. Elevators are used only for elevating or pushing the tooth distally. So those are the principles. Answer here is multiple adjacent teeth are to be extracted. That is when elevator can be used to advantage. Both the teeth can be removed. So I hope I am clear with it. Okay. So don't get confused. What you told is the correct principle of elevators. But here the question is multiple adjacent tooth. That is called Stobie's method of extraction. So this is an exception. Little confusion. That's why I kept here. Stobie's. Stobis. Stobie's method of extraction. When two adjacent tooth are to be extracted, put an elevator and just rotate. So elevators used for the extraction, distal most teeth in the arch and luxation of adjacent teeth. These are the uses of elevators. In case of extraction, interdental bone is used as fulcrum. Correct. That is the principle of elevator. The use of adjacent tooth as fulcrum is only permissible if the tooth to be extracted in the same visit. So you will use the tooth as a fulcrum if both the tooth in and out has to be removed. So you put in between and both the tooth goes out. So this is just a little confusion. So I hope I am clear with this. Next question. Mainly elevators in exodontia works on the principles of, yes, this is a very simple, lever 1 and 2, lever 3, or wedge principle. Exodontia, which principle? Yes. Others also, please respond fast. This much time will not be there in exams for you to think. But once the question is flashed, read it fast. Within 5 to 10 seconds, you should read it and try to respond. Even if it is wrong, doesn't matter. We are in the very initial stage. If you answer few questions, don't answer few questions. You cannot be selective like this. Right? Please answer fast. Okay. So the elevators, what we use in exodontia, works on lever 1 principle. Please understand, don't get confused. It's always lever 1 principle. Okay, that is the lever 1 principle. Inside details of that, it is there in our classes. In the detailed classes of exodontia, it will be there. Okay, lever 1. Now, if you have confusion, make a star mark. What is this lever 1, 2, 3? I should know more. So, like that, whenever you're studying, you get a question, you have a limited knowledge on that. So, you want to expand that, write it down. Once the class is over, go back to books and target those areas only. Yes, next question. I think this question we have done in our last session. Still, let's see who is the quickest now. All of the following statements about the inhaled tooth fragments are true, except, yes, it's like a photo finish. Everyone, put, it came. Very good. So, it usually enters the right bronchus, correct? And if the tooth is there, infection can happen, lung abscess can happen, bronchiostasis can happen. Yes, but it can be coughed out spontaneously, will not happen. Okay, no treatment is required. So that is a false statement. Okay, so this are called superlatives. Whenever this except, none of the above, or find the odd man out, these are called superlatives. So this may confuse you. So once you're reading the question, read the question very correctly, and the superlative, put an extra 2-3 times and try to relate it. Because this question we have done it earlier, it's very easy to tell. But if it's a new question, you may go wrong also. The superlatives will confuse you. So be very, very careful in any question if superlative is there. So this explanation I have already told you. So a chest X-ray has to be taken if any fragment of the tooth is missing. It is not there on your tray and it has been swallowed inside. So better to take a chest X-ray, and then if it is there through bronchoscope, you have to take it out. Okay, so you have to pulmonologist, you have to contact ENT people also, you have to contact, both of them will collaborate and get it done. Next question. Reactionary hemorrhage occurs after extraction because of. So now there are 3 types of hemorrhages: primary, secondary, tertiary. First you answer this, then I will come into the explanation. Reactionary hemorrhage. If you're wrong, no problem. Please answer. You can be wrong. If you're wrong, it shows that you're at least trying. Yes, very good. Now see that there are 3 types of hemorrhage. Whenever I'm doing an extraction or an impaction, blood is coming out. So at the time of surgery, if the blood is coming out, that is called as primary hemorrhage. At the time of procedure, if the blood is coming out, even if I'm doing a flap surgery, scaling, blood is coming out at the time of surgery, that is called as primary hemorrhage. So I give a suture, patient goes home. After 4 to 6 hours, till next 24 hours. So till 24 hours, if again the bleeding starts, that is called as reactionary hemorrhage. Reactionary hemorrhage. Right? So at the time of surgery, that is primary hemorrhage. 4 to 6 hours after the surgery, till first 24 hours, that is called as reactionary hemorrhage. And the reactionary hemorrhage occurs because of elevated blood pressure, or the sutures get disrupted. So here answer is high blood pressure, and all of you are correct for that. Same explanation. Intermediate or reactionary hemorrhage is within 24 hours. And after 24 hours, any bleeding, that is called as secondary hemorrhage. Point to be noted, after primary hemorrhage, we generally call it secondary hemorrhage. It's not like that. Primary, secondary, in between, intermediate or reactionary hemorrhage is there. So please do not get confused. So you can remember like a mnemonic, PRS. Primary hemorrhage, reactionary hemorrhage, secondary hemorrhage. PRS. There is R in between both of them. And secondary hemorrhage, after 7 to 14 days, post-operatively still bleeding is happening. So that is called as the secondary hemorrhage. Due to breakdown of the clot or due to an infection, it can happen. So that is secondary hemorrhage. Okay. So I hope the concept is clear. Primary hemorrhage at the time of surgery, intermediate or reactionary hemorrhage 4 to 6 hours after the surgery till first 24 hours, and after 24 hours it is, and up to after 24 hours means 1 day, until 7 to 14 days it is called as secondary hemorrhage, PRS. Next question. The best time of extraction in pregnancy is first, second, third, none. First, second, third, none. Okay, so all of you are telling second trimester. Yes, very good. The second trimester is the best one. Why first and third are not? We will discuss that. In the first trimester, the fetus is developing, organogenesis is happening. And at that time, any malformations can happen, developmental anomaly can happen. If the stress and strain is more, the mother is not able to handle that, right? It can eventually lead to malformations in the fetus. So that's why first trimester is never indicated. Second trimester, yes. Third trimester, very dangerous because a lot of steroid hormone, there will be a lot of hormonal changes in the woman who is going to deliver. So there is a lot of hormonal changes. Steroid hormones are manufactured at a very high dose. And when oxytocin, the pituitary gland will release oxytocin. And oxytocin causes contraction, okay, uterine contraction. So if the fetus is there and little stress and strain happened, the mother or the woman cannot handle that. And then the hormones are released little more faster and then contraction happens. Eventually, it can lead to premature baby, right? So immediately cesarean section needs to be done and the mother and the baby has to be rescued. It is an emergency condition which is not indicated. So be very careful. First trimester and third trimester, never do it. Okay. And you have to be very careful about the medications also. You cannot just write whichever medication you want. So here, make a note, the medication safe in pregnancy. Those medications, it's a separate thing. You read in pharmacology also. So these are related topics, what you should know. And then one more topic, what you should know in and around is, what are the drugs, if given during the pregnancy, what all changes will happen? Understood? If by mistake or by chance some medications are given to mother, right? So at first stage, if the mother takes, teeth are affected. The third stage, also teeth, generally teeth. I'm just giving you a clue. That is called as teratogenesis, right? So this is all, please read it. I'm just giving you related topics because in one class I cannot explain everything. I'm just giving you related topics. First thing is, what are the drugs safe in pregnancy? Second, if the drugs are given, which drug, what complications can happen? Staining of the teeth, tetracycline, all those things. I'm just giving you a clue. There's a table chart. Please read accordingly. Okay, next question. So this is how, when a question comes, you have to read in and around. You cannot just mug up the question, read there and finish it up. Never. Next question. A pregnant patient in second trimester falls in syncope. So during extraction of upper molar, she should be kept in. Always remember, a pregnant woman should never be kept in supine position. If it is kept in supine position, the weight of the fetus will compress the vena cava. And if the vena cava is compressed, the blood circulation in the mother will be decreased. The cardiac cycle will decrease. Okay, so always left lateral position. Now, what you have to read, the answer, all of you are correct, that is left lateral position. Now, your answer does not end here. In dental pulse book, oral surgery synopsis, you see there is one big table given over there. In that table, different conditions, how a patient has to be transferred, right? Suppose a patient is having asthma, the patient should not be made to lie down. We generally say syncope, lie down. Any problem, lie down. If it is asthma, patient should be sitting position. If it is syncope, supine position and head down, leg little up. Pregnant patients, left lateral. Like that, other conditions are also there. Please go and read that. Dental pulse synopsis. It is there in your book. Okay. So same thing what I told you. Inferior vena cava, the fetus will compress there and poor venous return and hypotension can happen in the mother. And then that is why left lateral side it is recommended. You should also know why also. Okay. Don't just mug up the answers like that. So here all different positions, some 8 to 10 positions are there. You should know how to do which position in what condition. Next question. A patient who is on dicumarol therapy. So it is an anticoagulant. So which laboratory test is most valuable in evaluating patient surgical risk? Yes, very good. So this is an anticoagulant. So basically, in anticoagulant therapy, when it is going on, prothrombin time is the one which is very helpful for us. Prothrombin time. So prothrombin time is increased in patients on anticoagulant therapy. So you have to first test it also. Test the blood, check the prothrombin time. So this prothrombin time is increased in patients with anticoagulant therapy or salicylate therapy. It is also prolonged in liver disease at deficiency of factor 1, 2, 5, 7, 10. These are all things you should know. Normal prothrombin time is 11 to 15 seconds. Normal prothrombin time is 11 to 15 seconds. Right. So extraction can be carried out when the prothrombin time is 1 to 1.5 times than the normal prothrombin time. The normal is 10 to 15 Newton. So 1 to 1.5. So that means 1.5. If you take it, 10 has the number. So up to 15 seconds, 1 to 1.5 times more if it is there, no problem. That is equivalent to 20 to 23 seconds. So even if the prothrombin time is 20 to 23, you can go for extraction. So that is why if any patient tells, sir, I am under anticoagulant, don't say stop aspirin, stop this and come after 3 days, 6 days, 5 days, I will do your extraction. No. Please check for the prothrombin time because the patient may be on an anticoagulant for a very long period of time. Or there could be a liver disease also. Every anticoagulant is not only for one particular reason. So maybe a liver disease is there. The prothrombin time may be increased there. So you need to double cross check and up to 1 to 1.5 times than the normal, you can go for the extraction. So 20 to 23 seconds is okay. This is also called as INR. Next question. In a patient who is on long-term steroid therapy. So steroid is basically taken by those people whose stress bearing capacity is very less. They are not able to bear the stress. So for them, the steroid has to be taken on a daily basis. Yes, I need others also to answer. Come on, this is a very common Viva question. Go wrong, no problem, but please answer. See, there are so many students here. Please answer. Okay, this is not a TV serial happening here that you will sit and listen like this. Okay, you tell whatever it is. I will see it later. Or now you tell, I will read later. That kind of approach is there. Never it will happen. You go wrong. 20 out of 20 questions go wrong, but please answer. Okay. Now, Please understand what I am trying to explain. Okay, a patient on long-term steroid therapy, what precaution to be taken before tooth extraction? Now, this patient is not able to handle stress. That is why he is taking steroids. So, for example, 100 units of steroid a person is taking on a daily basis. So, now that steroid what the patient is taking, that is for his normal survival. Now you are going to give what the you are going to do extraction for that patient. So during the extraction, you will give LA extraction. Again, the stress level will increase. So please remember, on the day of extraction, just before the procedure, you should double the dose of the steroid. That means if the patient is taking 100 units, before the extraction, give one more 100 units. If the patient was taking 50 units, before the extraction, again 50 units. So the first 100 unit, if suppose he is taking, the first 100 unit is for his normal survival. And the second 100 is for the stress what you are going to give. So here, the second option, additional steroids are to be given. And it is not additional, it is double the dose to be more precise. Please understand that it is double, whatever dose he is taking, double the dose. So whenever you're taking any patients, just ask him whether are you taking steroids or some tablets or anything you are taking. If he's not able to tell the answer which medicines he is telling, tell him to get the script. Next time, you defer the extraction, no problem. But if you do it just for few 200, 300 rupees, you may land up in problem. So that is why let the patient not know the medicine, but get the script. Next time when he comes, you will know that, oh, he's on steroid. Okay, this many mg, double the dose. So this is the same thing what I told you. You have to double the dose. Okay. So management of adrenal insufficiency, if it is there, patient will be on corticosteroid therapy. The patient should double the dose on the day of the surgery. Now some MCQs will come one day before the surgery, on the day of surgery, or after 1 day of the surgery, the doubling of the dose should be there. It is just before the procedure. Please understand that. It's not 1 day before, it's not 1 day after, it's not after the procedure also. Just before the procedure, double the dose. Next question. 1 day after mouth extraction, 1 day after complete mouth extraction, blue-black spots are seen on the neck of the patients. Okay. Blue, black. So blue, the blue is the indicator. Blue, black. So the patient is suffering from or indicates thrombocytopenic purpura, postoperative ecchymosis, impaired blood circulation, or cellulitis. It is after extraction. So something our extraction had done it. Right. So it should be not a long term, which is a short term, it has happened. So the answer what you have told is, one second, the answer what you have told is, yes, all of you are correct. It is post-operative ecchymosis. So it is actually large extravasation of the blood in the subcutaneous tissue. And the discoloration is because of breakdown of hemoglobin, that area, discoloration has happened. And basically this is seen in circumorbital, this area, circumorbital area, submandibular region, lips, floor of the mouth. So this part and this part, this ecchymosis is more commonly seen. So what is the management of ecchymosis? First you apply cold, then once it is okay, then you can give, for the distillation you can give heat therapy, cold followed by hot. And then proteolytic enzymes can be given to break down the clot. Okay, thick clot would have formed over there. So that to break down the clot, proteolytic enzymes can be given. So this is basically self-healing. Over a period of time, it will heal by itself. Okay, fine. Next question. A patient is on, a 55-year-old patient of myocardial infarction is of 75 mg of aspirin for last 6 months. So continuously he is taking aspirin. Now he has to undergo extraction for carious teeth. What are the steps to be done? Okay, so mixed answers. Okay, mixed answers are coming. Now, the old school of thought says that, first of all, why the patient is taking aspirin? I want others to be answered. So many people are there. Please participate. Only 4, 5 are continuously telling. 2, 3 are not telling at all. Generally, aspirin is blood thinner, you can call it, right? It will make sure that blood doesn't clot and it is in circulation. It will be always in circulation. Aspirin. Old school of thought used to say that stop 3 days or 5 days of aspirin, go home and come back. That is old school of thought. The new school of thought, that is even in your Burkitt's new edition, latest edition book, it is told if the patient is taking aspirin up to 75 mg, you don't stop. Because if you stop, more damage will be done to the patient rather than stopping. So up to 75 mg, don't stop. 100, 150 mg, you can take a consent and stop. That is the latest thing. I purposefully kept this and many of you have gone wrong here also. So extraction can be done as this dose of aspirin does not lead to marked bleeding during extraction. That is the answer. Answer number 1, okay? Please do not get confused with option 2 and 3. So this is the latest one, but you should know this. So such patients do not have increased risk of prolonged excessive postoperative bleeding. Risk of bleeding is very low, up to 75 mg. So you can carry out the extraction. Next question. A 32-year-old female patient underwent extraction of an upper first molar on the right side, and 0.3 millimeter of perforation was created into the sinus wall. So oroantral fistula has happened. What would you like to carry out? Cut-like operation, suture, give an antibiotic dressing and allow for secondary healing, or no treatment required? Yes, this is a very good question. Please answer. You go wrong, no problem, but please answer. 0.3 millimeter of perforation. Yes. Again, mixed answers. No problem. Good. You're answering. I'm very happy. I'm noting the names who are answering. Okay. So repeatedly 2, 3 names are coming. It's very good. So such people are the ones who are interested, who really want a seat. These are the ones who get seats also. You may be wrong initially, doesn't matter. No one knows in the beginning. Please understand that. No one knows in the beginning. What you know in the end, that matters. But to know that you know or you don't know, you should participate. No, that is why. Okay. So I got all the options. Everyone has opted different options. So let me explain this question. So you're extracting a tube, a perforation, a breach has happened. 0.3 millimeter is very small. 0.3, not even 1 mm. Not even 1 mm. So here, don't do anything. No treatment required. It will heal by itself. Now, you're telling, sir, 0.3 mm is very small. What is the criteria then? When are we going to do this? This is the criteria. If up to 1 to 2 mm, don't do any treatment. It will heal naturally. So here, 1 to 2 mm leave you're telling. This is the textbook, the protocols, what has to be followed. And our question is only 0.3 mm. So it comes under even below this. So don't do anything. If it is 2 to 4 millimeter, then follow the patient and advise the patient not to sneeze. Okay, not to use of straw and no pressure on the sinus. Tell the patient not to put pressure on the sinus. If it is 2 to 4 mm, still it is just an observation. You can put on antihistamines also. That's it. No need of surgery. For a period of time, secondary healing, it will heal. If it is 6 millimeter or larger, then only you need to refer to an oral surgeon, where the surgeon will come. He will take the buccal flap and the palatal flap. I hope you remember that. Right? Berger's flap, Ashley's flap. This you have studied in oroantral fistula. Different types of flaps are there. The flaps will come into picture only when your perforation is 6 millimeter or larger. But in cases if 2 to 4 millimeter, you are taking all the precautions, still it is not healing, then you can close it. This is textbook knowledge. Okay, MCQ, like you have to do this. But in a patient, if it comes to you on a private clinic, if you see a perforation, just give a releasing incision, reflect the flap, do a little bit scoring, and suture it over. Patient will be very happy. There is no need of any observations and all. He will be very happy with it. And there will be the communication is closed on the same day on private practice, on a clinical practice. But MCQ, there is a format which you should know. So 0.3 mm was our question. No treatment required. I hope I am clear with this. Okay. This classes recordings will be there. Please go back and see it again. Next question. Dry socket. Alveolar osteitis results from loss of blood in the clot in the socket. Is treated with re-inducing bleeding into the socket. It is a form of osteomyelitis, or it is common extraction of anterior teeth. Yes, all of you are correct. Very good. More people are participating. This is the Josh it should be. You should be putting it your best possible answer. See what happens. So when you start answering, what happens? Your brain starts thinking. A question comes, I am just seeing like this. Okay, some are answering, maybe one, maybe two. Okay, I will see it. Okay, no, two is the answer. Okay. But when you start thinking, you are stressing your brain. Whatever you have studied, all your knowledge is stored at some levels. So you are triggering that areas, you are waking that areas. So as a result, you are utilizing your intelligence and brain. So that leads to critical thinking. You start thinking. And that is very much required at a later stage. And over a period of practice, over a period of time, when you keep on start searching answer, rather than blindly marking A, B, C, D, you derive an answer and then mark an answer. Probability of getting it correct will be very, very high. So dry socket, basically, it is result of loss of blood clot in the socket, and it is generally in the posterior teeth, okay? And it is more common in the mandibular teeth. So those areas you should know: mandibular teeth, posterior teeth, 3 to 4 days. So this is more common. It's localized osteoarthritis characterized by acutely painful tooth. 3 to 4 days after extraction, very, very important. So what is the management? Just warm saline irrigation, no curating it up, and zinc oxide eugenol paste. You can put it, mix it in cotton, watch piece, and stuff it inside the socket. That acts as an obtudent dressing. Then after 48 hours, call the patient back, pick out the dressing, throw it out, just see how it is. If it is still, the bone is denuded, mix it one more pack, keep it, send back. Maximum you can give is painkiller, you can give that. Okay, patient will be fine very soon. Next question. Intake of which of the following leads to incidence of dry socket? Now, patients will be having so many medications. So, which medicines will increase the incidence of oral hypoglycemic or oral contraceptives? Yes, all of you are correct. This is the oral contraceptive drugs. If the patient is taking, incidence of dry socket is more. Okay, the estrogen level will be very high when the patient is taking oral contraceptive. Estrogen level will be very high, and that will dissolve the blood clot. So a study has been conducted. Women who are taking oral contraceptives, 20% more higher rates of dry sockets are there in them. 20%. Okay. So even for extraction, that is why case history is very important. You feel that what is there in case history. So dry socket comes, you know the management, but your wisdom, your knowledge should make sure that dry socket does not happen only. So a proper case history. If the lady is pregnant, other precaution. If she's on oral contraceptive, other precaution. So as a dentist, the mind should be always working on. And especially smokers, you should be very, very careful. Next question. The antibiotic coverage is mandatory before extraction in the following conditions of the heart. Yes, so this is a question which is a common question which you will get again in general medicine also. General medicine, pharmacology also. Here also. So 3 to 4 places you will get, even in pedo also you will get IP. Right. So this particular topic you should know very, very well. So mandatory and all of you are correct. That is congenital heart disease. So this is one table given over there. Please learn where the prophylaxis is recommended, where it is not recommended, right? Where it is mandatory, not mandatory. So congenital heart disease, what we have discussed is mandatory and required also. High risk category it is. Okay. Please learn this. Do not leave this question. It can come in 3 to 4 different subjects. It has come. Next question. Post-extraction bleeding in a leukemic patient. Leukemia. So it's a cancer. And the blood cells will be depressed. So what are the blood cells? RBC, WBC, platelets. So think that way. Yes. So it's a platelet disorders will happen. Leukemic patients, post-extraction bleeding is due to platelet disorders. And because of the depression in the bone marrow suppression, there will be anemia, thrombocytopenia, and decrease in neutrophils, neutropenia. And there will be spontaneous bleeding. So these are the key facts you should know about this. Okay. So that was all about extractions. Again, so many questions can be asked in extractions, hair positions, with whatever things I have discussed in the previous class. I am not putting it here so that repetition should not be there. Now this is about impactions. Red line, yes, very good. The red line tells the depth at which the impacted teeth is located. So now again you should know what is white, amber, red. White and amber also you should know that. Okay. Yes, this all of you have got correct. Now importance of white line, importance of amber line, importance of red line I have explained you in my previous class. That also can be an MCQ question. This is the explanation which I have already done. Next question. In WARF assessment, which we do for impacted molar, and WARF assessment is generally done in IUPA or OPG. Please put it in chat box. My question is, WARF assessment is done in OPG or in IUPA? WARF assessment is done in OPG or in IUPA? Please mention that in the chat box. I hope you're getting my question. Yes, very good. WAR lines, WAR, WAR lines, we check in IUPA, whereas WARF assessment, we check in OPG. So this is the difference what you should know. And A stands for nothing but your angulation of third molar. Okay, angulation of third molar. So W for Winter's classification. H for height of mandible. Where is the height of mandible? Here, here, here. Where? You're measuring for third molar, right? So the second molar is there. Distal aspect of second molar, draw one perpendicular line. That is the height of the mandible. Then angle of the mandible, this perpendicular distal aspect of second molar and on horizontal line touching the chin. This forms the angle. Angle of the third molar. Angulation. Where angle? Here. Right? Distal surface of second molar, vertical, and the a line drawn horizontal, which is connecting both of them, is the angle. Then R for root shape, F for follicle, path of exit. Next question. Ho and Colton describe the criteria to diagnose which of them. This is directly from the textbooks. Yes, please answer. Yes, come on. Okay. This is nothing but to, yes, answer has come. Yes, correct answer. The mandibular third molar root apices will be there, right? What is the relation of the root apices to the inferior alveolar canal? I have shown you one photograph in the last class. There are 7 or 8 different, whether superimposition is there or whether it is behind or widening is happening or the roots are getting narrowed on the canal. What is the relation of the root apices? So that was given by Ho and Poynton. So this is the classification. Related but not involving the canal. And then you have got related to the changes. And then you have got related to changes in the canal. So please learn with the help of a diagram. Right? It is purely in the textbook, it is there, in dental pulse, it is there everywhere. This area you should not miss. You have to learn this in and out. Okay, and one more thing, in the WARP assessment, the total score given in all the books, textbooks, what you are reading, even in the dental pulse book or other books, it will be written as 33. That is wrong. The answer is 16. Okay, why it is 16? I'll explain you during the long session when we take about the impactions. Textbooks are wrong. Everywhere it is wrong. It's not 33, it is 16. Why it is, I'll let you know. Please make a note of that. Next question. The direction of the bevel of the chisel during cutting is away from the bone to be sacrificed, towards the bone to be sacrificed, or independent. Okay. So now we have got two things, chisel and osteotome. So generally, chisel is towards the bone to be sacrificed. When you are hitting with a mallet, you will take the chisel, and towards the bone you will put, like the carpenter, how he does. From which side he wants to take the wood, that side bevel will be there and he will hit, and the wood will go. The chisel is mono bevel, only one side. And whichever side you want to remove, that side you will face. Towards the bone, it will be faced. The bevel is kept facing the bone to be sacrificed. So that is the protocol what you have to follow during chisel. But osteotome, it's by bevel. Both the sides it will be bevel, by bevel. So chisel is mono bevel and osteotome is by bevel. So do not get confused. Okay, this is a question which comes repeatedly and students get confused. Chisel is mono bevel and osteotome is by bevel. So the answer has come directly here. Lingual split technique, instrument used to cut is chisel. Now, what is this lingual split technique? This is used for mandibular third molar teeth. So, a third molar which is deeply seated. Now, this is the tooth, right? Now, this is buccal aspect and these are the two lingual aspects. So, this is buccal, this is lingual. So, this is mesiobuccal, distobuccal, distolingual, and your mesiolingual. Now, this part, distolingual, this area of the bone is there. We take burr and cut now. But lingual split technique is not followed. First of all, no one does this lingual split technique. This is an outdated technique. But the name is very big, lingual split technique. So very nice name. So that's why MCQs are asked. But it has got nothing to do with the common practice today. So distolingually, what you will do is you will take this, what you say, chisel, and at a 45-degree angulation, you will remove this lingual plate of bone. Now we are removing it with burr, right? But earlier we can remove it, or with this technique we can chip off the bone, and then all the vertical stops is created, and we remove the bone in and around and take out the tooth out. So 45-degree angulation, distolingual bone is removed with chisel. That is the explanation. 45 degrees, distolingual bone. Okay, so these are the things which you should know. Very, very interesting question. This is a very good question actually. While extracting a mandibular third molar, it is noted that the distal root is missing. Third molar distal root is missing. Where is that root thing? Where is the root tip? Come on, fast. So this question is little bit of space infection. Also, they integrated, but it is basically an infection. Okay. Okay. The root tip is in submandibular space. So please understand. The location of the root tip will depend upon the third molar tooth. How the third molar was there. If the third molar was standing straight, vertical, then the root tip, which is the round root, the root tip, it is in the submandibular space, down below the mandible. That was the question. So our third molar is standing straight. The root tip is in the submandibular space. If the tooth is mesioangular or horizontally placed, the root tip which is here, that will be in the pterygomandibular space, back side. And for upper, it will be in the infratemporal space. That's it. Very simple. Depends upon the tooth position. If it is telling distoangular, mesioangular, vertical, the root tip positions will change. Next question. Extraction of distoangular impaction of mandibular third molar can cause. Yes, distoangular impactions are called. It is the most difficult and more complications happen here. Why? Distoangular. It is like this. The crown is here. There is no space. Yes, there is no space, and when little force exerted, it will result in fracture of ramus of mandible. So this triangular impaction is difficult to remove because of its pathway of delivery. You cannot pull it backward. Outward you cannot take. There is no space. Right. So little more pressure you apply, the ramus can get fractured over there. Watts incision. The anterior releasing incision in ward flap designed for mandibular wisdom surgery is placed. Where is the anterior releasing incision placed? Mesial to second molar, mesial to first molar, distal to second molar, or midway to CEJ. Watts incision? This is your Viva question in final year exams. Yes, try to answer. Answers have come, but it is not the correct answer. Some okay, mixed answers are coming. Very good. So difference of opinion. Yes, I like this. Okay, so let us study this Watts incision. The answer is mesial to second molar. Watts incision. Okay, see this photograph on the right side. This is your third molar. This is your second molar. Mesial to first molar, you give a Watts incision, and it should not be straight. Okay, it will not come down. It is given like a curve. Why it is not given straight? Because your facial artery comes here, placental muscle, facial artery. So you should not go down. You should give it like a curve. So what is the length of this anterior releasing incision? 6.23 millimeter. It's written here. So mesial to second molar 6.23. And then you have clavicular incision over here. And then you have got distal releasing incision here, a long incision which goes up to the ramus. That is 25 millimeter. 25 millimeter. So this length and all you should know, okay? The distal releasing incision is 25 millimeter. Clavicular incision is the dimensions of the tooth. And then anterior releasing incision is very small, 6.23. So 1:4 ratio. Anterior releasing is to distal releasing 1:4 ratio. If this is 6, that is 6 for the 24, something like that, 25. Which nerve is near to mandibular third molar likely to get damaged while removing third molar? Yes, this is medial aspect. So the question is medial aspect. So medial aspect means inside aspect. Inside. So inside is your lingual nerve is there. So inside lingual nerve is the answer. So answer is already given here. By mistake it came. It is the lingual nerve, which is there on the medial aspect. So which all aspect, which all nerve passes through. You can take a screenshot of this. You can learn this. Okay. So that's it. We had a very long session today. We discussed extractions, impactions. There are many more questions like Peterson's difficulty index. What are the values? Some scenario cases will be given. I didn't include the classification of impactions because that is very easy. Class 1, class 2, class 3. So like that, questions will be asked. So this is a sample session to make you understand how questions can be triggered. And today, see, whichever questions I was asking, it's basically 3-line, 4-liner question. It's a case-based scenario. A 55-year-old, 25-year-old person with some medical complications and ultimately extraction. So this is how the general medicine part also will be mixed up in this. Now, because we are reading surgery, it's very clear it's dealing with surgery. But in the question paper, you have to find out it will be all mixed, which is surgery, which is general medicine. So it all will be mixed. So you need to be a little careful. So dear students, please understand that if you follow seriously and if you really want to do MDS, start early. The story of the tortoise and hare, you know, the person who starts early gets extra time. Right? Initially, I am not telling that your confidence level will be very high. After some time, some pharmacology subject or general medicine, your motivation level can come down. Again, you need to pick up. So that is how the role of mentors comes into play. So ups and downs will be there. Don't judge yourself if you're not able to answer few questions. I don't know anything. No one knows in the beginning. What you know in the end, that matters. And if you have any other queries, any other doubts, you can, my number is there in the group. You can talk to me personally also. Okay. So all the best. Thank you.